Welcome everyone. My name is Stefan Johansson. I'm one of the persons in the 99 NICU team, and on behalf of everyone in the 99 NICU team, I would like to welcome you to another Neovation webinar. This is the second in a series of webinars where we will be taking a look at new innovations shaping the future of neonatal care. And our idea with this series is that we wanted to bring you new innovations and technologies in neonatology. And this series of webinars is also done in partnership with neonatal startup companies and with guest speakers. And the format for this webinar, for each webinar, is that we will have a very short presentation by each of the partners. And then we will have two 15-minute guest lectures delivered by neonatal experts. And today we would like to welcome Monivent and Neola, two Swedish startups supporting this webinar. And we're delighted to have Professor Lista and Dr. Harris as our guest speakers. Please, Vicky.
So I have got the great job of introducing our two guest speakers today. So welcome, a very warm welcome to Professor Lista. He is a consultant neonatologist. Now I'm going to hopefully try and pronounce this correct, at the Vittorio Buzzi Children's Hospital, and an honorary professor at the University of Milan. His PhD thesis, which he completed at Maastricht University in 2016, was titled Respiratory Management in the Neonatal Transitional Phase, the Role of Sustained Inflation to Enhance Non-Invasive Respiratory Support. His areas of interest in particular are neonatal resuscitation, respiratory and nutritional intensive care of very preterm infants. So we're really looking forward to hearing his talk this afternoon. And our second speaker, more from my geographical area, is Dr. Chris Harris, who's a consultant neonatologist at King's College Hospital in London, in the United Kingdom. He also works as a researcher with King's College London, where he also completed his PhD about neonatal ventilation and long-term outcomes. As well as studies of resuscitation, he's also focused on long-term follow-up of the UCOS cohort, and also of the benefits of providing neonatal care in Uganda. After we've heard from both of our guest speakers, we're going to have a joint question and answer session. So please put all your questions in the chat, and we will put them to the panel and moderate that at the end. So please feel free to post anything in the chat for our speakers or the companies.
Oh, then I would like to hand over the word to Maria Lindqvist at Monivent, please.
Great, thank you so much for the possibility to be here and present today. Can you see everything all right? Great. So my name is Maria Lindqvist, and I'm one of the co-founders of Monivent. And at Monivent, we work to support a more gentle and effective treatment of newborns in need of respiratory support at birth. So for me, it all started about 10 years ago during my final year at the university, when I was put in contact with two neonatologists and a lung researcher who themselves had the need for better monitoring during manual ventilation. They felt like they were working in the dark, and they also done a small study, observational study, that showed large variations of pressures and volumes during manual ventilation. And this was a big eye-opener to them, and also the starting point for Monivent. So we target those 3 to 6% of all newborns that need manual ventilation at birth, where we see that both too small and too large volumes can cause serious injury to both lungs and brain, which we will hear more about today. Yet the healthcare are lacking good tools to really evaluate the treatment. So that's why we developed the Monivent Neo 100. It's a monitoring device that measures the airflow directly in the face mask. And this data is transferred wirelessly to an external monitor, providing continuous feedback on several ventilation parameters, such as tidal volume, leakage, and pressures throughout the treatment, which allows to make the necessary adjustments for a more gentle and effective ventilation. And the small size and the simplicity of the device makes it easy to integrate as an add-on to existing ventilation equipment, and also with less impact on current clinical practice. So Monivent as a company, today we are 8 employees working in the office in Gothenburg, Sweden. Since 3 years back, we're also listed on the Swedish stock market. We have 2 products on the market, which is basically 2 versions of the same concept. So one is for training and education on mannequin, whilst the other one is for clinical use in the delivery room and the NICU. So the products are being sold through a network of distributors covering over 25 countries, mainly in Europe, where we sell the clinical device, but the training device is also being sold in, for instance, US and Australia. So we are happy to see that the number of users are steadily increasing and get a lot of interesting stories about how the products are making a benefit out there. So it's exciting times in the company, and I'm happy to welcome you to get in touch for any questions that you might have about these products after the webinar. Thank you so much.
Thank you so much, Maria. And then I would like to hand over the word to Neola and Tatiana, where are you? There you are, Tatiana Kotyuk. Hope I pronounced your name correctly.
Yes, please. Hello, everybody. I'm very glad to be here. And I'm clinical manager of Neola Medical. It's medtech company, and I will present you today groundbreaking breaking technology of 24 hours non-invasive monitoring of lungs for saving lives of preterm born infants. Sorry. Neola, it's non-invasive continuous monitoring of lungs with instant detection of pulmonary complication. Its standalone bedside medical device, values of relative lung volume and absolute oxygen gas concentration are continuously shown on the touch screen monitor and measures of left and right lung respectively. Small, lightweight emitter and detector probes are positioned on the skin of the patient thorax above both lungs separately and give 24/7 days per week real-time data values. Adhesive materials completely biocompatible for the skin and safe for these babies. Objective decision support for earlier detection and treatment of pulmonary complication leading to better care about this baby. As we know, the respiratory distress syndrome is still a leading problem of the preterm health issues. And unfortunately, bronchopulmonary dysplasia, it's morbidity that present of the risk still very high. The device will be able instantaneously to detect atelectasis, pneumothorax, or changes in the oxygen gas content in the left and right lungs. Due to, for instance, intubation tube misposition, mucus in bronchi, or other respiratory complications. The measured parameters are stored, allowing clinicians to scroll back and examine data from the previous 24 hours to observe any gradual trends, and it could be in any time of the day. What Neola offers: fast detection of pulmonary complication, preventing future morbidities, but it's very important for their following life. Improvement care for this vulnerable patients population and decrease time stay of them in the NICU. Easier to use that can decrease the time for visual observation by the nurses. Thank you for your attention.
Thank you so much, Tatiana. And then we are ready to move forward with the first 15-minute presentation by Professor Lista. Are you able to share your presentation?
I am the first, before Chris.
Yes, yes, Professor Lista,
Oh,
you were the first speaker, if that's okay. Wonderful.
Okay, thank you very much for inviting me. The title of my presentation is the RDS and Lung Protective Respiratory Support. It's a long way, the development of respiratory system. And I think that it's important some crucial steps like the production and storage of surfactant close to the 22 weeks of gestational age. When a baby is born at 28 weeks of gestational age, you have to think that the lung is between the canalicular period and the sacral period. So it's vulnerable for the ventilation and it's a high risk for the ventilator-induced lung injury. We know that the bronchopulmonary dysplasia still remain a challenge for neonatologists because the 50% of the babies below 27 weeks of gestational age may be affected by bronchopulmonary dysplasia. PPD is not only a problem for Europe, but it's a global problem, also for North America, Asia, and Oceania, in particular for the babies with a very low gestational age, 23, 24, 25 weeks of gestational age. And we know that PPD is a multifactorial disease, but we know that the ventilation is one of the most important predisposing factors for the development of the BPD. When we speak about the lung protective respiratory strategies, we have to think that the protection has to start in the delivery room when we have to allow the transition. We have to try to allow an homogeneous lung volume, and we try to avoid early damage just in the delivery room. When the baby is transferred to the NICU, if the baby needs to be mechanically ventilated, we have to try to prevent or limit lung injury, and we try to optimize tailoring the respiratory support. In this slide, you can see in summary the postnatal intervention for prevention lung injury, appropriate neonatal resuscitation, transition. We have to try to reduce the use of high concentration oxygen, early use of nasal CPAP, sulfatory replacement therapy, and in case of the baby need to be mechanically ventilated, it's very important, a tailored ventilation. Just after birth, the baby have to generate a delta pressure that it's very important to move the fluids in the airway. So the delta pressure is needed to overcome the airflow resistance. Then delta pressure is needed to overcome the surface tension, so to open the alveoli to maintain an open and to generate a functional residual capacity within seconds to minutes. The problem is that the preterm baby, in many cases, it's able to have a breath at birth, but it's unable to allow a complete transition to create an earlier first seed. This is the reason why frequently a preterm baby need to be supported, for example, with a continuous positive airway pressure. From the literature, thanks to this numerous randomized control trial performed also with very tiny baby, we know that the nasal CPAP is a viable alternative to mechanical ventilation. And we know from this meta-analysis that the non-invasive respiratory support started in the delivery room, then maintained it in the NICU, it's able to reduce the incidence of that BPD. This is the reason why the recent European Consensus Guidelines published in Neonatology in 2019 suggest for preterm babies with a spontaneous breathing to be stabilized with the CPAP of at least 6 centimeter water by mask or nasal prongs, and to use the intubation only for baby do not respond to nasal CPAP or PPV. The problem is that the majority of 50% of baby initially in nasal CPAP for the management of RDS need to be intubated in the first week of life. And these authors understood that the CPAP failure occurs early in the first 8 hours of life and is more frequently marked by increasing oxygen requirement. And they understood that this need of increase of oxygen requirement was related to the not capacity for the preterm baby to create an early FRC. And this is the reason why this baby show a high rate of CPAP failure. How we can try to reduce the CPAP failure, how we can try to guarantee a more homogeneous lung volume in the delivery room. There are many works in progress about the use of higher level of CPAP as a static CPAP in the delivery room, 6, 8, 9, 10. And for example, in my unit, we are studying a static low PEEP level set at 5 versus a static high PEEP set at 8 in babies with a gestational age less than 29 weeks. And we want to verify the effect on oxygenation. And actually is running the Polar trial. Is a multi-center randomized control trial in which a static PEEP is matched versus a dynamic PEEP with a progressive step-by-step increments of PEEP and then a decrement of PEEP. And the target is the reduction of BPD. So probably in the future, we can have some answer from this study in order to understand if a different use of CPAP in the delivery room may enhance the FRC, so enhance the success of CPAP. Anyway, some babies need to be mechanically ventilated, and when we start the mechanical ventilation, we have to try to optimize the mechanical ventilation in order to prevent the ventilator-induced lung injury. If you consider the RDS in the acute phase, it's a restrictive respiratory disease, which we have a low lung compliance, the chest wall is unstable, and the baby are unable to guarantee a normal FRC. So it's very important to try to have a good pressure to open the alveoli to maintain them open. The problem is that in many cases, we have only a not homogeneous lung aeration. And we have to try to reduce the length of mechanical ventilation because longer is the mechanical ventilation is and higher is the incidence of BPD. Which is the first message? The first message is the necessity to avoid the fightening of the baby with the ventilator, because if the baby fine with the ventilator, we have a continuous fluctuation in the tidal volume, fluctuation the level of PCO2, so high risk of volutrauma, barotrauma, high risk of air leak, and high risk of brain injury. In order to reduce this problem, we have to synchronize the baby with the ventilator. And we know from the literature that the synchronization could reduce the number of hypoxemic events, could improve the gas exchange, can reduce the volume of breathing and duration of mechanical ventilation, reduce the need of sedation and analgesia. If we compare two different modalities of synchronization, assisted control versus SIMV, we know, for example, that assisted control in the acute phase of RDS could reduce the timing for weaning from mechanical ventilation and tidal volume fluctuation. It's very important a trigger sensitivity, because if the trigger is not effective, we can induce a muscle weakness, and we have to avoid the risk of auto-triggering. Another important issue for lung protection is to give surfactant when the surfactant is necessary. And for the premature baby, the European Consensus Guidelines suggest to give surfactant when FiO2 need is more than 0.3. Anyway, we know that probably this threshold for the surfactant replacement therapy probably is not a complete right criteria. In the future, we can be helped by the lung ultrasound and the oxygenation index in order to understand better when the surfactant is needed for preterm baby with RDS. When we decide to give surfactant in order to be lung protective, we have to give surfactant early, because early versus delayed surfactant therapy can reduce the risk of acute pulmonary injury. In particular, can reduce the risk of pneumothorax and PIE. In order to reduce the BILI, biotrauma, volutrauma, tracheotrauma, barotrauma, it's very important the strategies in order to guarantee lung volume optimization. We have to try to set the lung volume on the deflation limb or the pressure volume curve. When we set all our parameters, PEEP, peak inspiratory pressure, inspiratory time, flow, the target, the results is the changing on the tidal volume. So we have to try to take attention on the tidal volume. The problem is that the same tidal volume generates a different strain index when we consider different animal. If we consider a man, a rat, a rabbit, mouse, the same tidal volume generates a different strain index. And if you consider the man, if you consider an adult, a term newborn or preterm baby, the same tidal volume can generate a different damage because the border between the FRC, the tidal volume and injury zone is very, very close for the preterm babies. Anyway, we know that the target volume ventilation, it's able to reduce the occurrence of that BPD, severe IVH, pneumothorax, and electromechanical ventilation. This is the reason why the recent European consensus guidelines suggest for the conventional mechanical ventilation as a primary choice, the use of target volume ventilation. The problem is that one size does not fit all, because, for example, the very tiny babies suffer the dead space of the flow sensor. So probably we had to increase just a little bit the tidal volume. If you generally use a tidal volume around 5, for the baby with a birth weight less than 1 kilo, we have to increase just a little bit the tidal volume, for example, around 6, in order to guarantee a normal gas exchange. And if the baby is evolving versus BPD or versus an established severe BPD, because we have a enlargement of the trachea and we have an increase of the dead space into the lung, we have to increase the tidal volume in order to guarantee the same CO2 washout. Not only target volume ventilation, another important issue in order to guarantee a lung protective strategy is the use of adequate PEEP level. Because if you can reduce the swinging of the alveoli, we have to research the optimal level of PEEP. It's not always easy to understand which is the normal level of PEEP in order to set the tidal volume on the deflation limb or the pressure volume curve. We can use the lung hysteresis because due to the lung hysteresis, we know that we can use a lower transpulmonary pressure to maintain the lung volume in the expiration when we match the same pressure that is required for the inspiration. So observing the saturation target and the need of FiO2, we can try to generate a PEEP trial, step-by-step increment of PEEP until we can reduce the need of FiO2. So we probably arrive close to the upper inflation point. So we can reduce step-by-step our PEEP pressure. And when we observe a drop of saturation, we probably are close to the closing pressure. So we have to increase again just a little bit the level of PEEP. This is a patient in which we have demonstrated that this strategy is good in order to choose the optimal PEEP. And if you can see, there is a progressive increase of PEEP with a progressive implements of 0.2 centimeter of water every 5 minutes. We observed a progressive reduction in the need of FiO2. When we observed a drop in saturation and need to increase again the level of FiO2, we have to increase again the PEEP level in order to set the lung volume on the deflation limb of the pressure volume curve. Another suggestion in order to be lung protective is to use the pulmonary graphic, in particular the scalar record or the flow. It's very important to observe the trend of the curve or the flow. It's very important that inspiratory flow, after its increase, go down and to the baseline and immediately start the expiratory flow. Only if the trend of the flow is like this, you are respecting the time constant of the lung. And using this record, you can identify which is the adequate inspiratory time. For example, in this case, the inspiratory time is too short, so you have to increase again in order to find the optimal inspiratory time. And also it's important to choose the optimal expiratory time. In this case is too short, so you have to increase the expiratory time, reducing the respiratory rate. When the conventional mechanical ventilation is a target volume ventilation, use low tidal volume and use an adequate PEEP level, the conventional mechanical ventilation is similar to the high frequency in order to reduce the risk of BPD. So in summary, in order to use a conventional mechanical ventilation lung protective, we have to start in the delivery room to allow the neonatal transition. We are work in progress about the research of the optimal CPAP, static or dynamic. In NICU, if it's possible, you can use a non-invasive respiratory support in case of valid spontaneous breathing, early surfactant administration, and when the baby needs to be mechanically ventilated, remember that use the synchronization. You have to choose the appropriate inspiratory time and expiratory time. You have to use a targeted volume ventilation and use a lung volume optimization strategy using a tailored PEEP level, adequate monitoring, an intensive assistance 24 hours and all the week. And when you start the mechanical ventilation, remember you have to try to weaning as soon as possible the baby, because the baby needs to be extubated as soon as possible. And if you are the possibility to have a closed loop control of the oxygen, it's very important in order to reduce the risk of lung injury induced by the ROS. Thank you very much for your attention.
Thank you so much, Professor Lista. And we wait with the questions until we have heard Dr. Harris and his talk. So please, Dr. Harris, you can now share your slides.
Thank you. Thank you very much. Sorry for the slight delay there. I would like to talk to you. Thank you very much for inviting me. I'd like to talk to you about using monitoring during resuscitation and try and make a case for using it more often in our routine practice. I'm sorry, are the slides moving along?
No, they are not moving, in fact. But if you now they are moving.
Perfect. Sorry about that. So using monitoring during resuscitation is incredibly important to us at King's. I think most people who would resuscitate premature infants particularly realize the dynamic process that resuscitation is, with rapid changes in lung volumes and compliance. In the UK, we tend to use a fixed pressure device like a T-piece, but even applying a steady pressure to the lungs, and each time you do so, you may not be delivering the same tidal volume. And here this slide shows how your FI formation during those first few breaths changes the tidal volume even when a set pressure is applied to the lungs. And even more dramatic changes in lung volume occur during resuscitation when infants take their first breath, and indeed when we change science dramatically when we give surfactant. Indeed, our premature babies are at high risk of long-term morbidity, and we know that in their general care, there are things that we can do that change the outcome for our babies. For example, carbon dioxide control. We know that abnormal carbon dioxide levels are associated with intraventricular hemorrhage. And in fact, the longer that infants are exposed to these abnormal carbon dioxide levels, the more that risk is. Even if we have, on average, normal carbon dioxide levels, if we allow our infants to experience fluctuations in those levels, we can also induce intraventricular hemorrhage and bronchopulmonary dysplasia. So how does this fit into what happens at resuscitation? Well, we know that using high tidal volumes in animals during resuscitation leads to lung damage. And it's in fact the high volumes rather than the pressures that seem to be the predominant cause of that damage. And when we at King's College Hospital looked at the tidal volumes used in an observational study of resuscitation of preterm infants, we found that the tidal volumes varied quite dramatically, even between breath by breath. Others have studied the carbon dioxide levels in babies once they reach the neonatal unit. And in one study, they found that up to 20% of infants who received surfactant on the delivery suite were in fact hypocarbic when they reached the NICU. And this suggests that those infants may have experienced fluctuations in their carbon dioxide levels whilst they are being resuscitated. Neonatal did a wonderful study of 165 infants born prematurely, and they very clearly showed that infants exposed to higher tidal volumes, and those tidal volumes they defined as those above 6 mils per kilo, were more likely to experience severe intraventricular hemorrhage. Now, we know that higher tidal volumes are often associated with lower carbon dioxide levels. And this is because of that link with minute ventilation and arterial carbon dioxide. But we also know that carbon dioxide changes the resuscitation phase as infants take their first breath, and that pulmonary vasodilation occurs, allowing the washout of carbon dioxide from the blood. And we at King's, we wanted to understand whether, in fact, carbon dioxide levels in infants during resuscitation gave us more ability to predict their long-term outcomes. To do this, we measured resuscitation, we took resuscitation equipment with us to the birth of every preterm baby, and we used a Philips Respironics NM3 monitor. And this monitor is good because it has a small dead space of pressure, flow, oxygen saturations, and carbon dioxide using a combined sensor. Anyone who's used the Philips NM3 knows that it's not the easiest machine to read, and it doesn't give flow data on the screen, and so we used Dedica to give us our outputs. Just to show you what that looked like, the monitor fit very easily with our existing resuscitation equipment. And at the end of the resuscitation, we were able to look through the traces, and we were able to see flow, pressure, end tidal CO2, and a calculated tidal volume from that. Just of note, you can see here that there is a little dip in pressure during the resuscitation trace, and this is an infant taking an active inflation during a resuscitation. So back to our study, and we recruited who are less than 33 weeks of gestation. And we used retrospective consent, which I think now most of us are using this, but at the time it was quite unique to allow us to perform these studies. And then we would then go back to ask the parents for their consent to use their obviously taking our study through the relevant ethics panels, etc. And we found that this mode of consent has changed what we can study in the delivery room, and been very helpful to us. For 50 infants, and we looked at over 30,000 breaths. We then divided our study population into those that had an intraventricular hemorrhage and those that did not. And as expected, we found that those who had an intraventricular hemorrhage during their neonatal stay tended to be of a lower gestational age and a lower birth rate. But quite surprisingly, when we looked at the APGAR score at 5 minutes, we found that there was no difference between the group. And this suggested to us that, in fact, it's not the sickest babies that tend to go on, or the sickest babies at the time of birth, that necessarily go on to have an intraventricular hemorrhage, and it may be something that we can alter as neonatologists. We looked at the results, and I'll draw your attention to the bottom of this table, and you can see that in terms of conforming to that MEAN study, indeed, those that had the highest tidal volumes tended to have more risk of intraventricular hemorrhage. But indeed, those with the lowest end tidal CO2 recorded during the whole of resuscitation also were more likely to go on to have an intraventricular hemorrhage. And this, we felt, was a combination of both the higher tidal volumes, but also when we looked at the inflation rates, we found that the rate of inflations was much, much higher in those that went on to have an intraventricular hemorrhage. We then went to divide our infants who had intraventricular hemorrhage into those that had mild intraventricular hemorrhage, which we've called grade 1 and 2 intraventricular hemorrhages, and those that had the most severe, which would be the grade 3 and grade 4. And whilst both groups did in fact have higher than that 6 mils per kilo tidal volume, we found that the end tidal CO2 was lower again in those with the most severe intraventricular hemorrhage. And that suggested to us that it's maybe an additional insult to these infants to be exposed to hypercarbia as well as those large tidal volumes. And it goes to what Professor Lista was saying before, that this is multifactorial. It's unlikely to be one thing that puts these infants at risk. So that study was looking at the whole of resuscitation, and it depends, I guess, where your labour ward is situated with respect to your neonatal unit. But sometimes our resuscitations can go on for 30, 40 minutes in the delivery room before we reach the neonatal unit. And we wanted to look at those first 10 minutes of a resuscitation, because we feel that that is most likely to be the time that lung compliance changes most dramatically. When we looked at 60 infants who are born at less than 34 weeks, we found that, as expected, low oxygen saturations recording at 5 minutes was predictive of infants not surviving. But interestingly, we also found that in those that had severe intraventricular hemorrhage, they also had a lower end tidal CO2 at 5 minutes. And that suggested to us that even though prolonged end tidal CO2 is certainly bad for our infants, even short or relatively short periods of low end tidal CO2 might be causative of these intraventricular hemorrhages. We have to caution this with the knowledge that pulmonary dynamics, including the blood flow to the lungs, changes quite dramatically as well. And it may be that what we're seeing here was in fact poor pulmonary vascular flow as much as low end tidal CO2. So in conclusion, looking at these studies, we have seen that those with the lowest end tidal CO2 had the highest incidence of the most severe intraventricular hemorrhages. And this was in a patient population where there was no difference that we could see at how well or unwell these infants were at birth. We feel that measuring tidal volumes and carbon dioxide may help improve the rates of intraventricular hemorrhage. But if you'll allow me one digression, just to say that actually providing a respiratory function monitor in the delivery suite may not be the answer to this. During our training period, we asked our trainees who were taking the equipment and using the equipment in the delivery suite, and we asked them to interpret various readings. And we found a large understanding of those readings. For example, 33% of our trainees said that they were present on the monitor. And so it can be difficult for trainees to interpret data from respiratory function monitors. And I think it's really important to say that having a simple output for trainees and maybe even midwives to look at would certainly help. And I think what we're trying to do, carbon dioxide monitoring is also incredibly helpful even during. We were measuring carbon dioxide in both ventilated and non-ventilated infants. And it is very easy to measure carbon dioxide if you have good seal around your mouth. So I'll end just by saying thanks to Professor Green. I would have loved to have been here today, and Dr. Jenkinson, who's one of our research fellows here. Indeed, all the research fellows that contribute to the research at King's College Hospital, and of course the infants and their families as well. Thank you very much.
Thank you very much, Dr. Harris and Professor Lista, for your presentations. And now I would like to open the floor, or rather the chat and the Q&A part of the Zoom window. You find them below in the window. And please share your reflections and questions from the participants. And while we're waiting for the first question, I would like to ask you one thing about the cause and effect to both of you. I mean, there are lots of complications related to less good respiratory care, but how certain can we be about the cause and effect, for example, to intraventricular hemorrhage? What do you think? What is the chain of events leading to it?
But if I can try to answer to your question, as you could see from the Cochrane review, the use of the targeted volume ventilation, it's able to reduce the risk of severe IVH. So I think that this strategy is effective both in protecting the lung and also protecting the brain, because it's very important when we manage a very tiny baby to try to protect the lung, but not also the lung, but in particular the brain. So I think that a strategy that try to be lung protected, to take attention to the tidal volume, may be very effective and reduce the cost of the brain damage and the lung damage for very tiny babies. So also in my unit, we use the respiratory function monitor in the delivery room. We have participated to the monitor trial. And from the monitor trial, even if we didn't find any differences in terms of tidal volume when you use a blind screen or open screen, but the meta-analysis demonstrated that using the respiratory function monitor visible, you can reduce the severe IVA. So I agree with the very interesting data produced by the group of Christopher Harris. Compliments.
Thank you. I'm about to pay you the compliment back, Prof. Lista, because actually Prof. Lista's work on inflammation from tidal volumes has been a huge motivational driver for us at King's in understanding the cause and effect, as you say, exactly. And I think that carbon dioxide and the vascular tone effects, the fluctuations in carbon dioxide have are absolutely important, particularly when it comes to brain injury. But I think I'm a respiratory interest doctor, but every now and again my mind wanders to other parts of the body, and actually for neonates, inflammation that starts in the lungs because of our ventilation strategies or even our resuscitation at birth is very poorly controlled systemically within the infant. And I think it was Beverland et al. Showed the high levels of inflammatory interleukins in the blood, leading to poor outcomes, both in terms of mortality and indeed BPD. And others have shown that global inflammation can go on and make the infant more susceptible to those vascular changes resulting from carbon dioxide. So I think I don't think we're going to find that golden bullet of that thing that stops infants from having it. And I think it's a long-standing battle to reduce inflammation in these young infants, and try and safeguard what we can in terms of tidal volumes, as a way to do that, which is, I think, certainly the way that we see things moving in the future.
So what you are saying is that it could well be a combination of vasotone hemodynamic effect, but also like some inflammatory component in the etiology of IVH that is connected to the lung strategies that you apply early. Is that how I understand you?
Yeah, I think that's what we're heading to, and at different time points, I'm always fascinated by looking at inflammation and tidal volumes in newborn infants versus those with established bronchopulmonary dysplasia, and this one size not fitting all. And I think that as human beings, we don't like change, we like to find the answer. But I think we need to be more dynamic in neonatology, to exactly what Prof Lista was saying, adjusting to the baby in front of us, using flow volume loops and good monitoring to be able to adjust our ventilation strategies.
I think we've got a couple of questions in the chat now too. Shall I do a bit of moderation? So the first question actually is very similar to one I had, which is a bit more about implementation, I think, of these technologies. So Francesco has asked a question for Dr. Harris. Do you want to elaborate on how a simple, helpful display for the resuscitation bed might look like, in your opinion? And I'll have a follow-up question after that, actually. But I'll let you answer that one first.
Thank you. So I think, as an example, when I started doing the resuscitation research, I found it overwhelming, all of the things that I could look at and see. And as I got more experience with using these tracers, I became more adept at looking not just at tidal volumes and end tidal CO2, but how the flow might change and how that might direct whether I've got leak or whether even tubes are in the right positions, etc. I think that is very possible to do if you use the equipment every day of your life, and I was going to every delivery. I think the majority of resuscitation that occurs in the world, not just in the UK and at King's College, is, for example, the first resuscitation that a midwife will do when a baby is born unexpectedly in poor condition or before the neonatal team arrive. And for people who don't look at these traces every day, it can be very difficult to pull out the effective numbers. And we found that using devices like the Monivent device, don't know if I'm allowed to sell equipment on it, but certainly a display that turns a different color when you're giving too much volume. Those kind of visual cues are very helpful. I think that an end tidal CO2 that changes color, although we have had difficulties with things like PD caps, etc., because it's the sensitivity of those PD caps that tend to be where it falls down. But certainly color change has been a game changer for us at King's, but also having very simplified displays with big numbers on screens that are easily portable. Those are, I think, what we're aiming for and what we envision for the future. And of course,
yeah, thanks.
Cheap. That's too cheap, so we can get them everywhere.
But I also think, as I'm from a nursing background, we are by those bedside monitors and the ventilators all the time. And I wonder how much, in terms of implementation and understanding, like you spoke about trainees understanding, actually, this is probably more of a comment than a question, not helpful. But I wonder about how much we really utilize that from a nursing perspective, really, in terms of what we understand, and a survey or an assessment of nursing understanding in the way that you've done trainees would probably be quite interesting. But that's just a comment. We actually have a question so in the chat, so I'm going to just ask another question, which I think maybe we could start off with Professor Lista and then move on to Dr. Harris. But Dirk has said, thank you for both wonderful talks. Could you please tell us your thought about early high frequency oscillation, especially in terms of early higher CPAP levels?
Thanks for this question. I generally use the sister controls plus volume guarantee for the majority of preterm babies with RDS. Anyway, when there is a very tiny babies, for example, preterm infants less than 25 with the gestational age, for example, 23 or 24, there are high risk for BPD or severe IVH. I prefer to use high frequency as an early intervention, and I use the same strategy showed for the research of the optimal PEEP. So I researched the lung volume optimization with the research of the optimal continuous descending pressure using the strategy performed by the group of the MC in Amsterdam by Anton van Kam. And I prefer to associate the high frequency plus the volume guarantee. And I use these strategies, high frequency plus volume guarantee, also for babies that are at high risk for lung hypoplasia. For example, baby with a prolonged rupture of the membrane. And so when I suspect the risk of lung hypoplasia, so I prefer to use the high frequency because the mean airway pressure is reduced when arrived to the last alveoli. I want to give a comment about the lung inflammation and from the inflammation that is at the beginning of the IVH. Since many premature babies born from mothers affected by coronary pneumonitis, inflammation started just in the uterus. So I think it's very important to try to reduce the lung inflammation. So the strategy in the delivery room and NICU can help this baby to reduce the risk of inflammation. That is the first step for the brain and lung damage.
Thank you, Professor Lista. I have, well, one question from myself, but also a similar question from Victoria Lima. And I would like to ask both of you what you think about the role of sustained inflation. And the question from Victoria Lima is about high PEEP and how we can control the risk of pneumothorax in relation to high PEEP and sustained inflation.
Yes, this is a fascinating question because it's one of my best interests in the research. You have to remember that at the beginning, when the baby is birthed, the lung is fluid filled, so the time constant is very long. So there is no high risk to generate a pneumothorax because the delta pressure that you use, if you use a prolonged inflation, you only use the pressure to move the fluids along the airway, so you don't use the pressure directly on the airway. This is the reason why generally we don't have a pneumothorax when you use high PEEP or the sustained inflation in the delivery room. When the lung is cleared from the fluids, you have to take attention to the level of PEEP because you can induce the pneumothorax. How we can control? It's not easy. Anyway, actually we have some instruments that can help probably in the future the research of the optimal PEEP, like for example the forced oscillation technique, the FOT, or the electric impedance tomography that can help the clinicians to understand which is the optimal level of PEEP in the delivery room and in NICU in order to try to reduce the risk of pneumothorax.
Thank you. Do you have some more comments, Dr. Harris, from your viewpoint?
It's hard to follow Prof. Lista because Prof. Lista is certainly the the final word on PEEP. We did do a prolonged inflation study here at King's, and we found very good results both in our clinical outcomes and also in our intracellular outcomes, where we showed that when we stretched lung cells in a lab, comparing our standard resuscitation practice, which was to give breaths, versus a sustained inflation, that the inflammation released from cells was lower in our sustained inflation model compared to our standard inflation model, which gave us great hope that the sustained inflation multi-centered trial would echo our results. And we're a bit at a loss to explain why that large multi-centered trial showed that we should stay with what we're doing at the moment. And we're looking for the next avenue to explore with that in the delivery room.
If I can add some comments about the results of our the SAIL trial, in which we tested the sustained inflation versus the routine resuscitation. The trial was stopped early after we enrolled a good number of patients, but the group of baby randomized to receive sustained inflation showed higher mortality in the first 2 days of life. The problem is that these babies show an higher percentage of IVH of pneumothorax. So we don't know which were the reason why this baby showed an higher mortality, but we know that it was not related to an increase of IVH of pneumothorax. Still remain a question how to tailor the sustained inflation in order to translate the optimal benefits that we found in the animal studies in the humans. Probably in the future, if we can monitor much better the capacity of the sustained inflation to generate a functional residual capacity, we can have another good choice to facilitate the transition of the baby.
Thank you so much. Before we close, I would like you to look into the future a little bit. I mean, the automated oxygen delivery is about to come, I hope, at least. But I'm thinking about mechanical ventilation, because it's still a lot of art in that. And I'm thinking about inspiration time, PEEP levels, volume guarantee, which is here already. But I feel there are other things that can be automated in our best interest, so to say. What do you think about the future medtech development when it comes to respiratory support, and specifically maybe mechanical ventilation?
I think we're using automated oxygen here in a research capacity, and hopefully moving over to use it as part of routine care within the NICU. I certainly think we need more information about transition of saturation levels through delivery and resuscitation. I think that's key. But I also would like to see us be a bit less binary in terms of looking at just changing oxygen levels, because oxygen levels aren't just dependent on what your FiO2 is, it's mean airway pressure and synchronization, etc., etc. And I see a really big role for artificial intelligence and system learning in producing algorithms that adjust not just to the oxygen levels of the baby, but help us with synchronization, adjusting pressures and tidal volumes in the same way that Prof. Lista was describing before.
I love very much the automatic control of oxygen. We have published some papers about the positive effect of the automatic control of the oxygen, both in the acute phase of RDS, and also I think for the chronically ventilated infants, for example, for the VPD infants. My dream could be to use the automatic control of the oxygen just in the delivery room, then in the NICU, from the admittance until the discharge, because I think that oxygen, it's another important issue to control, because it can generate severe damage for the brain, the eye, the lungs, and for the bowel.
Hi, Gustav here. Isn't it quite stupid of us to believe that we manually can ventilate a child in the straight after delivery, but afterwards we need a machine to do it for us. Why wouldn't we start with a machine straight away just to keep everything better controlled? And then we can keep our eyes on the CO2 levels, we can keep our eyes on the oxygen levels and just forget about the ventilation for a while.
Completely agree with you. I think the short answer as to why, so just to explain what we do at King's, we have now a transport incubator with a ventilator that provides volume guarantee ventilation. And so immediately that the baby is stable, we switch straight over to our ventilator if that's what's required. And hopefully we're all moving down the route of trying not to ventilate our infants, and indeed not to intervene as much as we can for our infants. But for those that do need it, we switch to volume control straight away. We have trialed some devices that would ideally help us in those first few moments of a resuscitation. But at the moment, the technology is not quite there in order to give us good volume controlled resuscitation with a leak, with a machine that's portable enough and carryable enough to every delivery, and also at a price that people can afford. Because you know, if you imagine trying to put a machine in every delivery room, we've got 20 delivery suites here at King's, that would be at the moment well over £1 million. And you know, this is the NHS in the UK, we don't have money, full stop. So trying to convince them that is quite hard.
Thank you so much. Now we have used up the full hour, and it's about time to close this second webinar in the Neovations series about innovations and innovative thinking in the future of neonatal care. And I would like to thank the partnering companies, Maria from Monivent and Tatiana from Neola Medical, and of course also thank our speakers, Professor Lista and Dr. Harris, for sharing your knowledge to every one of us. And last but not least, I would also like to thank all attendees for joining this second webinar, and we look forward to meet up next time. As I said, it will be on the 14th of March, and we will tell all about this in our newsletter, but also on Twitter, etc. So thank you so much, and wish you a nice evening, everyone.
Thank you. Bye-bye.
Thank you.
Bye-bye.